Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is ocular surface squamous neoplasia. It is basically abnormal growth of the neoplastic dysmorphic cells on the ocular surface. It is one of the most common ocular malignancies. If we talk about its prevalence, it is mostly present and found in areas which are near the equator, almost 30 degrees of equator. It is mostly prevalent. Some people associate this to the high UV light exposure. It has also got a very high association with HIV patients. Human papilloma virus has also been shown to associated with this uh, ocular surface squamous neoplasia. Different types of viruses are there. For example, 6811 cause benign tumors, and 16 and 18 cause malignant. And tumor suppressor gene 53, it's also has association with the development of this surface neoplasia. Grossly, it has been classified into three types, that is benign dysplasia, number two, precancerous conjunctival intraepithelial neoplasia, and the third one is malignant squamous cell carcinoma. And after that, it has got further classification. Grossly, if we talk about this virus, it is causes a squamous carcinoma, which is pearly gray in appearance, and variable pigmentation, vascularity, and leukoplakia. It can be confirmed with the anterior segment OCT, and the gold standard confirmation is, of course, the biopsies. And usually surgical options are there for the management of these cancers, and it is considered if 4 o'clock hours of the limbus is involved and its diameter goes up to 15 millimeter, then a surgical option is a good option. And usually we take 4 millimeter from the margins of the growth in the lesion, because this vessel, this tumor spreads to along the basal layers of the conjunctiva. So it is important to take, when taking it out, 4 millimeter margin along it. When we talk about the surgical treatment, this is a 4-step approach. First of all, we have to take it from the corneal side. Alcohol-assisted epithelialectomy is done, 2 millimeter margin from the corneal side, and we can use even crescent knife. We have to shave it off from the corneal side. And also, once we have done it from the corneal side, the scraping and the removal or shaving of the this growth, we go towards the conjunctiva side also. Then we start from the conjunctival side, keeping a margin of 4 millimeter. But if we see that the sclera is also involved, then 0.2 millimeter of the sclera is also taken along with, that is sclerectomy is also done with this. So these two sides, from the cornea side it is coming and the conjunctiva side, it is shaved off. It is shaved off from the two sides. And once these two sides meet over there at the limbus, then it is all taken in one chunk over there from that. As I told you, the first, when we remove it as a chunk from the corneal and the conjunctival side, we remove the whole chunk. Now the third step is that applying the cryo. It is it is basically 2 freeze thaw method we apply over there. From the conjunctival side, we apply almost 2 millimeter from the conjunctival margins, and when we come near the limbus, we maintain a distance of at least 1 millimeter. So this way we make sure that all those cancerous cells along the conjunctiva are also dead. After that, that bit bare area which has been developed over there, that has to be covered with something, and for that we usually apply the amniotic membrane transplant, so that bare area is covered. And after covering this bare area, we can close the eyes, but if literature, other options are also there. If we feel over there that limbal stem cells have been compromised, many surgeons have also attempted limbal stem cells transplantation. So the thing is, usually when the surgery is done, two sets of instruments are used. One set is removed when we are removing the mass from the cornea side and conjunctiva side, and minimal use of the BSS, and area is kept dry over there so that there is a minimal spillage or contamination from that area to the nearby areas. So in such cases, antimetabolites have also some proven role. For example, if you go for mitomycin C, that can also be applied 0.04% 4 times daily. 1 week it is used, and after that 1 week it is off for 3 cycles. The other antimetabolite which is very helpful in controlling this is 5-FU, 5-fluorouracil. That is 1 week it is used and 1 week it is off. So these are the available antimetabolites which are being used. So it can also be used before the surgery to decrease the bulk of the tumor mass, and it can be used intraoperatively. If you have to use it intraoperatively, once it has been removed, the whole mass over there, you can apply it. Then the strength is 0.02%, and it is applied for 2.5 minutes in that area. So, and even it can be used after surgery is done, post-operatively. So there's different ways these antimetabolites drops can be utilized. This is an anterior segment photograph of a case managed with us in the case U. You can see a well-grown conjunctival lesion, vascularized, and it is encroaching up to the cornea, up to the pupillary margin, and you can see how big this one is. Another anterior segment photograph, you can see vascularized growth, well localized, encroaching up to the cornea from the temporal side in the left eye. Before surgery, we also did his UBA, and we found out that that the growth was so much that it was causing some pressure over there, leading to the narrowing of the anterior chamber angle. You can see over there in the left side, you can see some areas the angle is getting narrow. If you look at this, please, that one, the slide, this is showing the moderate to high internal reflectivity of this lesion, and it's very clearly shown over here in the both sides, right or left, you can see over there. This is the report of the patient. You can see 16 into 10 millimeter size of this lesion, and it is not involving the subconjunctival, scleral, or even deep cornea is spared. So it is mostly a superficial lesion involving that area, and to some extent it is causing pressure effects and anterior chamber angles, and even the posterior leaf, we see that the posterior chamber is also being compromised because of the pressure effects over there. As per their sonology reports, they found that maybe it will cause a postpupillary block glaucoma because of the pressure effects. So as I mentioned earlier, we basically used mitomycin eye drops 3 cycles to decrease the bulk of this lesion, and after that we went for the excision biopsy with the cryotherapy in the typical 4-step fashion. It was done, and so the area was quite big that had to be covered. So we used this amniotic membrane transplant to cover that big area over there. You can see we have applied this amniotic membrane transplant. Here you can see post-op follow-up. You can see that AMT is well applied over there, secure in that area, while the cornea from the other side is clearing up. The inflammation is settling down over there. This is another anterior segment photograph. You can see how the inflammation has settled down and the anterior chamber angle is well formed, and you can see the amniotic membrane is perfectly placed on the lesion site. Later on, follow-up image, you can see that area is absolutely clear. Of course, there is some thinning in the limbal area which can be seen, but there was no more staining of that area. And as far as the report of that one is concerned, it was moderately differentiated squamous cell carcinoma from the biopsy point of view. And we also involved our internal medicine team. We did different tumor markers to find out any metastasis over there. CT scan was done of the abdomen, thorax, MRI, all these modalities, and the teams were involved to find out any metastasis. And later on, the patient was quite fine. We are still following this patient, and you can see how that interesting case, it was occupying that much bulk area, was removed over there, and now just it is showing improvement signs on follow-up. So this patient was managed by excision biopsy, and the patient is fine, but sometimes the lesion is that much aggressive that involves the other structures, deep lying structures, and eyelid margins are also involved. In that options, you have to take the help from the oculoplasty team, and sometimes you have to go for the enucleation and even exentration to save the life of the patient. I want to thank Professor Abdullah Al-Fawaz for giving me these slides, and I also want to thank my respected audience for attending this presentation. Thank you.